Good morning, everyone. My name is Aditi Patel, and I will be giving the introduction for my colleague, Dr. Xiaobo. She will be giving her talk on the review of the brain and heart axis. Is it the problem of the brain or the heart? Sorry, the problem of the heart or the brain? Dr. Zhao grew up in Binjiao, China. She graduated from Binjiao Medical College, where I learned that the school motto is actually the benevolent mind and heart, which is apropos for her talk today. She earned her PhD in neuroscience at the University of Southern California. She completed research projects on intracellular cascades mediating neuronal damage in animal models of neurodegeneration, as well as signaling regulation of neuronal phenotypes and the alteration of phenotypes of sensory neurons and sympathetic neurons with simulation to different neurotropic factors in vitro culture models. She's so modest that she doesn't even tell people that she has a PhD, it was news to me to find out. She did her internal medicine residency at Jacobi Medical Center, Albert Einstein College of Medicine in the Bronx, US. She is now a first-year fellow, completing her first year of cardiovascular fellowship at VCU. I am so honored to be giving this introduction. I've have clinic every week with Dr. Zhao, and safe to say that it's been great learning and so much fun. Welcome, Dr. Zhao.
Thank you very much for the very nice introduction, Dr. Patel. And thank you very much for all for giving me the opportunity to share my interest today, which is a topic of my interesting brain heart axis topic. Is the problem the heart or the brain? First, I wanted to start my topic with a little bit review of the anatomy of the brain heart axis. First, look at the picture from the top to the bottom. The level of the heart, the cortex, thalamus, and hypothalamus cerebellum. The cortical level is, we know that is responsible for the high-level functions. And among the cortical levels, the prefrontal insula, somatosensory cortex, and the limbic system are particularly important in the brain heart axis. And it's as part of the limbic system, the amygdala and the hippocampus are most important to regulate emotion, memory, and context with functional connections to the prefrontal cortex. Specifically, under the hypothalamus level, the paraventricular nucleus of the hypothalamus is the main factor of hormonal stress response and can activate the hypothalamus pituitary adrenal axis by secreting the corticotropin. And within the medulla level, the rostroventriculateral medulla is the final common efferent pathway for acute blood pressure and blood flow elevation. In contrast, the dorsal vagal nucleus promotes parasympathetic signal to the heart. And the interesting fact is that there are more significant, more postganglionic, sympathetic as well as parasympathetic nerves at the base compared to the apex of the L ventricle, which could contribute to the pathophysiology of Takotsubo syndrome. And conversely, from the bottom to the top is the efferent pathway. It begins with input from chemoreceptors, baroreceptors, and by reaching to the thalamus, eventually it reaches to the insular cortex. So why this is important? Now it has been well understood that after stroke, patients can develop numerous cardiac injury, which we'll talk about in detail later. But the severity of cardiac damage largely depends on the size and location of the stroke. This was well studied in numerous cases. This picture was one of the numerous examples. It was actually a pretty old study back in 1980s. It was well established animal model in rats. It's called middle cerebral artery occlusion. I used to do a lot of this animal models when I was doing research. Basically, it involved inserting a nylon thread through the common carotid artery all the way to the middle cerebral artery to occlude it. It is a basic MCO model. Specifically in this study, you can see clearly there was evidence of elevated concentration of both of the norepinephrine and the epinephrine in the MCU model compared to just occlude the common carotid artery and the sham study. Now the question is, if neurogenic pro-inflammatory process plays a role in cardiovascular disease. Well, we all know that the cytokine have effects on the neuronal action in a lot of neurological disease, such as neurodegenerative disease, Alzheimer's disease, epilepsy, or cerebral ischemia. And we also know that there is the evidence of clinical reports in that patients diagnosed with cardiovascular disease have a high level of pro-inflammatory cytokines, such as interleukin-1 alpha, interleukin-6, TNF alpha, or CRP. Anyway, the inflammation is the key driver. It all begins with endocellular damage and cholesterol crystal accumulation. While upregulating the numerous adhesion molecules such as ICAM, VCAM, and variety of selecting, it promotes aggregation and transmigration of inflammatory cells. And under the molecular level, it is important to know that formation of this multi-protein inside of the macrophage is called inflammasome. The formation starts when the macrophage had the second hits from either hypoxia or accumulation of a crystal. Then it further regulates downstream of those interleukin-6, TNF alpha, or interleukin-1 beta. Now let's talk about the key clinical trials anti-inflammatory therapy in secondary prevention. One of the most famous trials is CANDLES. It involves canakinumab, which targets interleukin-1 beta, and third trial, which involved methotrexate. Unfortunately, this is a revealing trial. Then we'll talk about our famous COCAT and LODOCO-2 trials. Okay, first, canakinumab. It is a medication target interleukin-1 beta. It involves a large patient population, more than 10,000 patients with history of MI, and those patients has to have evidence of a high baseline level of high sensitivity CRP larger than 2. And the interventions randomly assign the patient's population into different doses of this canakinumab every 3 months subcutaneous injection versus placebo. And the median duration of follow-up was 3.7 years. And it was found that, look at the top of the graph, it shows high sensitivity CRP significantly reduced compared to the placebo and the compared to the medication group with largest effect in the largest dose, 300 milligram group compared to the placebo. And in the specifically 150 milligram group, there was 15% of relative risk reduction in MACE. However, the trial wasn't carried over because it was found to have a higher incidence of a fetal infection sepsis in the canakinumab. Next is the methotrexate trial. It is also a very large study, involved more than 4,000 patients population. Those patients have to have MI history or multivessel coronary artery disease, and either with type 2 diabetes or metabolic syndrome. Patients were randomly divided into either treatment group versus placebo. But unfortunately, they didn't find any significant difference impact on MACE, as well as interleukin-1 beta, interleukin-6, and CRP level. There wasn't any significant difference. And then the trial stopped early with mean follow-up only 2.3 years. And they found actually it had this elevated liver enzyme level in the methotrexate group, as well as decreased leukocyte count, decreased hematocrit, and elevated in the incidence of non-basal cell skin cancers. So the question is, what is the difference compared to these two trials? It was found that in the baseline patients population, majority of patients were already started on statins. However, compared to CERT trial, the CANDLES population patients' baseline LDL was significantly higher, actually above the targeted guideline target 70. And secondly, patients in the CANDLES trial had to have baseline high sensitivity CRP, as we mentioned, but those were not required in the CERT trial. And it was also found that there are a large percentage of smoker in CANDLES trial, and we all know that chronic smoking have a relatively high level of inflammation, which also can explain it. And most importantly, because of the CANDLES trial target the interleukin-1 beta specifically, it further regulate the downstream interleukin-6, and there was significant reduction in the high sensitivity CRP, but there wasn't any significant changes in their CERT trial. Then we'll talk about our famous colchicine. It has been long studied and well-established anti-inflammatory effect. Actually, people have been using colchicine more than thousands of years. It was initially used in ancient Egypt, ancient Greeks, and Turkey as well. The mechanism was because the colchicine was vividly uptaken by the neutrocyte. It binds the microtubule and eventually affect the cytokine release, and then further prevent the aggregation and transgression of the neutrocyte. Now it's been found that colchicine has a beneficial effect in cardiovascular disease. Specifically, we'll talk about the COCOT trial. The patients has to have MI, and very recent MI was in the past 30 days. It was a pretty large clinical trial involving more than 4,000 patients. And it was found that colchicine has a beneficial effect. If you look at the hazard ratio, it's much higher in placebo compared to the colchicine group. And there were some adverse effects. Patients always report some kind of GI side effect, but interestingly, they didn't find any significant difference compared to the placebo versus the colchicine group. There was a significant difference in terms of pneumonia, but the risk is very low, only 0.9% in colchicine group and 0.4% in placebo. Now we know that colchicine plays a role in acute MI, and how about the chronic coronary artery disease? Then there was a second trial involved more than 5,000 patient population, and the patient has to have evidence of a coronary artery disease, either diagnosed from angiography versus those patients can have a CSA score larger than 400. And patient has to have clinical stable and symptoms more than 6 months. So the patients were randomly divided into either colchicine group versus placebo, and the median duration follow-up was 28.6 months. And you can see there was significant reduction in hazard ratio in colchicine compared to the placebo group. So this is a very promising study, and eventually, last year, FDA approved colchicine as a secondary prevention of cirrhosis. So this is a very nice review algorithm suggesting that two scenarios that we can initiate colchicine. One is when the patients were hospitalized for acute coronary syndrome, the colchicine can be initiated during the same hospitalization stay. Of course, the patient has to be on the gold standard medical therapies, including possible left heart cath, PCI, or of course, patient has to be on the high intensity study. And Or in the second clinical scenario is if you see some patients with chronic coronary disease, stable angina symptoms more than 6 months, you can always consider to initiate colchicine. But several things that need to be taken into consideration because of the side effect of colchicine, especially when patients have a diagnosis of chronic kidney disease, and GFR is something you always have to keep in mind. And also keep in mind that the above trial that we just talked about exclude the patient with severe heart failure with EF less than 35%, or they are in the immunocompromised state, or we always have to take into consideration of drug-drug interactions. And one thing they suggest is you can always get a baseline high sensitivity CRP level, and this gives us an idea of the residual inflammatory risk. All right, let's move on to the next topic, the effect of neurologic injury on the cardiac function. One of the most popular topic is the stroke heart syndrome. As we all know that we always, almost every time, very often, we get a consult from neurology service for numerous cardiac manifestation after the stroke onset. The peak was observed within the first 3 days post the stroke. People can often seen and found to have acute T prolongation, ST segment changes, inverted cerebral T waves, or impaired in the baroreceptor reflex, and cause acute hypertensive crisis post-stroke. And about 1/3 of patients was found to have newly reduced EF. Actually, it is found to be the second leading cause of death in post-stroke, right after subarachnoid hemorrhage. So the mechanism behind it can be explained by the brain-heart axis. First, the stroke activates the HPA axis, leading to an increased fat released into the circulation. And this can also occur at the level of myocardial nerve endings. In the immediate setting, the increased sympathetic tone can cause arrhythmia. Chronically, long-term, the chronic exposure to catecholamine can lead to mitochondrial dysfunction, calcium overload, and trigger oxidative stress. Eventually, it causes cardiomyocyte necrosis, hypertrophy, and fibrosis. And on the other hand, stroke also promotes microgliosis, endothelial cell activation, and release of cytokines. And this was also seen the evidence that some of the pro-inflammatory cells infiltrates inside of the myocardium, which shows some suggestion of there is some non-specific inflammatory response after the stroke. So evidence of first ever ischemic stroke was associated with increased risk of incident cardiovascular events was demonstrated in this study. Very large patient population based cohort study involved the resident in Ontario between 2002 and 2012, which age of larger than 66-year-old. Those patients were without known coronary artery disease. And it was actually found that first ever acute ischemic stroke patients without known heart disease have 25 times higher risk of incidence of MACE. And 5 times even higher risk between the 31 and 90 days. And the risk subsequently subsided, but still like 2 times higher thereafter until year 3. Because of the time-varying risk of MACE, cardiovascular complications are considered as part of stroke heart syndrome if they occur within 30 days of the event. So then here we have this very practical clinical question. What are we going to do if we got this consult from neurology service that patient has a bit of Pauley? why there's such a troublemaker when we ask the question, but actually, this is actually a class 1 recommendation. The cardiac biomarker has to be obtained after the stroke because it's timely identification of acute ischemic stroke patients with cardiac disease may improve the outcome. So what am I going to do? We suggest serious measurement of this troponin. If we see more like a rise in the flow pattern, it's more associated with acute cardiac injury. It is associated with higher short-term mortality. If it is more like a flattened trend, probably it's more beneficial. Unfortunately, current guideline does not have a specific data to support whether we call it type 2 MI versus type 1 MI. But just something keep in mind, even though you eventually decide to send those patients for left heart cath, but only 1/4 of those patients were found to have a capitulation. So this is a very nice reviewed algorithm published in JACC. So what are we going to do after we find the high sensitivity troponin elevation? First, you want to, as I said, send multiple series of troponin to see if there is a risable pattern, if it's larger than 20% change, dollar change. If it is yes, this is more like acute coronary artery injury. Then I will want to see if the patient has more classic presentation, like classic chest pain, if there's any ischemic EKG changes, abnormalities, potentially whether those patients can be a candidate for left heart cath. But you always have to consider those contraindications in setting of acute stroke, whether the patient has a hemorrhagic conversion, whether there was a large stroke and the patient has multiple cerebral microbleeds, if the patient can tolerate that or not. Or patient have evidence of sepsis, PE, or acute heart failure, something that you could blame this more like a type 2 where patient has more atypical presentation of chest pain. Or this could be a pure neurogenic myocardial injury where patient does not have a typical chest pain, or the echo is more like a Takotsubo kind of like a picture, QT prolongation, or cerebral inverted T wave. Now we know that acute cardiac injury can be a complication of stroke. And the question is, can stroke also be a complication from MI? The answer is yes. This is analysis from the Global Registry of Acute Coronary Events. It shows that post-MI stroke was rare. It was only 0.9%, but it has a very high mortality rate of 32.6. And the incidence of stroke is higher, of course, in a STEMI compared to non-STEMI or unstable angina. You can see from this table clearly. And it is also reasonable to imagine that non-hemorrhagic stroke were more significantly common among patients with non-STEMI than in other groups. Hemorrhagic stroke tended to predominate in patients with STEMI. Now the question is, if the CABG or PCI was associated with a high incidence of stroke. This is a collaborative individual patient data pooled analysis of 11 randomized clinical trials comparing CABG versus PCI using stents. And you can see clearly from the top table, the 5-year stroke rates were significantly lower after PCI compared to CABG. But look at the bottom of the graph. If you divided the timeline into within the first 30 days, after the 1 month to 5 years, you can see there was clearly reduction of rates in the PCI compared to the CABG group. And there were not significant difference compared to these two groups after 1 month up to 5 years. And the greater risk of stroke after CABG compared to PCI was also found to confined to patients with multivessel disease and diabetes. of course, the 5-year mortality was markedly higher for patients experiencing stroke within 30 days after revascularization. And overall, this graph show you the 35% in-hospital stroke occur within the first 6 months of hospitalization, and patients with acute MI have elevated risk of ischemic stroke compared to patients without acute MI up to 12 weeks. And this was counting for PCI CABG-related stroke, exclude patients from prior concurrent AFib. All right, next we move on to a very famous topic, the arrhythmia-related stroke. Traditionally, what we thought was that AFib caused desynchronizing of the atrial contractility, which caused a thrombotic formation in the left atrial appendage. Once the embolism got dislodged, it caused a stroke. But now it seems like there is a new model. Both the aging and systemic vascular risk factor cause mechanical changes in the atrial and the cerebral substrate that leads to the stroke independently of AFib. So the AFib could actually be a manifestation of a normal atrial substrate, which is a causal etiology for both AFib and stroke. Several studies support this hypothesis. The patient-based case control study, which is found that left atrial enlargement is associated with increased risk of ischemic stroke. This was even found after the adjustment of other stroke risk factors, including LVH and AFib. And another similar study, which specifically looking at the EKG evidence of left atrial abnormality, which was defined as P-wave terminal force in these V1 larger than 4,000. It was a marker of left atrial abnormalities such as fibrosis, dilation, and elevated bone pressure. A very large cohort study involving 14,000 patients. And they found that there was a higher incidence of stroke occurring those with baseline LE abnormalities. And again, this was after adjusted for potential confounder incidence of AFib. And interestingly, this is another study involved in the pacemaker and defibrillator patients. And they wanted to examine if there is a temporal relationship between the subclinical AFib larger than 6 minutes in duration and stroke or systemic embolism. What they found was actually out of those 2,000 patients, after the 3 months visit follow-up, ischemic stroke and systemic embolism were found in 51 patients. And out of this 51 patients, AFib was detected 26 patients. And eventually, only 4 patients were having evidence of the AFib within the 30 days prior to the event. And notice that there were 8 patients that were found to have AFib that was after the stroke occurred. So this is a new concept. It's called AFib detected after stroke. So AFib was actually found to be in 1/4 of the acute ischemic stroke and TIA patients, and the incidence is up to 8 times higher among those ischemic patients compared to propensity matched individual without stroke. And this concept actually included in the 2020 European Society of Cardiology guideline for diagnosis and management of the AFib. It could comprises cardiogenic versus neurogenic or mixed, but it still remains debating. Actually, there was some studies show there was a difference between the onset of a recurrent stroke in patients with non-AFib versus this AFib detected after stroke. Actually, you can see this trend. The AFib detected after stroke has a similar risk versus compared to sinus rhythm, and the risk is much higher in AFib with patients with non-AFib. The risk is similar in congenital heart failure and MI and coronary disease as well. So potentially this could suggest that there was a different mechanism behind it. So this is a summary of the mechanism. As we know that the stroke now could disrupt the automatic balance once the automatic regulation was abruptly disappeared. There was trigger for focal ectopic failure and eventually caused paroxysmal AFib. Or there's inflammation play a role in this process and cause a re-entry circuit formation and eventually cause the paroxysmal AFib. And study has also shown that both inflammatory autonomic phenomena are more severe in the acute phase, usually after a few days, a week. And eventually, the inflammation can clear much quicker compared to the autonomic function recover. Maybe this could potentially give you a target for AFib prevention in future. Lastly, the future directions. As we just mentioned, there isn't a clear guideline to refine which patient population require urgent coronary revascularization. Currently, there is an ongoing study called PRAISE trial. It is a prospective multi-center observational trial. It looks specifically for the clinical symptoms, troponin levels, as well as EKG and echo and coronary angiogram. And eventually, the diagnosis of ACS will be made by an endpoint adjudication committee, and the follow-up will be conducted to report neurovascular events. Hopefully, this study will help to refine the algorithm and develop some guideline for cardiac workup in ischemic stroke. And lastly, but not least, registered data will have to answer the question whether there is distinct clinical profile of stroke-induced heart injury or whether certain treatment can improve short or long-term outcome. And this ends my presentation. Thank you for your attention. Now I'm open to questions and comments.
Thank you, Dr. Xiao. That was a wonderful, wonderful talk on the brain-heart axis. If it's okay with everyone, I'd like to hold off on questions for Dr. Xiao's talk until we have an opportunity for Dr. Ali to give his talk. And without further ado, Dr. Turlington, if you'll give his introduction.
Dr. Patel, thank you very much. It is my pleasure to introduce Reid Ali. Reid is one of our first-year fellows. He completed his undergraduate training or education at James Madison University before moving to Norfolk, Virginia to complete his medical education at Eastern Virginia Medical School. He then came to VCU Health for his internship and residency in internal medicine and was selected and had the privilege to be one of our chief residents of the internal medicine program afterwards. While he was a chief resident, he focused on trainee education and improvement of resident education. Reid was born and raised here in Richmond, Virginia, and has enjoyed being in his hometown and caring for his hometown patients over the past 5 years. And he is looking forward to VCU's strategic future plans to improve access to care to both within the city and our rural neighbors. Without any further ado, here's Reid Ali. Thank you, Reid.
Thanks so much, Dr. Turlington. I really appreciate that introduction. I will share my screen now and get my slides up. I'd like to give special recognition to my KICU mentors who provided the impetus for this talk today. So I'm going to be discussing heart failure and congestion following MI, searching for new paradigms of management. So the learning objectives today is to refresh our knowledge on historical trials of patients with acute myocardial infarction complicated by heart failure and or congestion, and to identify recently proposed therapies to manage post-MI heart failure and whether they are successful. And then finally, recognize major themes of future research which may impact the modern management of post-MI heart failure. So the outline is kind of mirrors these objectives. So we'll do a brief review of prior clinical therapies. We'll discuss new literature for the novel proposed therapeutics and their perceived success or lack thereof, and then discuss future science and broad concepts to help address the burden of heart failure patients following acute MI. Just some epidemiology to kind of set the stage. So heart failure post-MI is classically divided into 3 clinical presentations: heart failure at the time of MI presentation, heart failure developing during the hospitalization for their myocardial infarction, and then heart failure onset after their index hospitalization for MI. Heart failure at the time of presentation, interestingly, has increased from about 4% in 1992 to 1994 to 12 to 13% between the years of 2001 to 2011. And then the heart failure during hospitalization has actually decreased. There's some hypotheses for this. One of the main drivers is that our pre-hospital care, especially our EMS colleagues, has markedly improved from 1992 to the present day. And so we're seeing more patients that otherwise might have died in the field. And then one of the big reasons that the heart failure during hospitalization has decreased is really the emergence of effective revascularization with PCI. So there are wide variabilities citing the increased prevalence or decreased prevalence of heart failure during hospitalization, but specifically the Sweetheart Registry reported a 46% in-hospital heart failure complication during the thrombolytic era, and subsequent decrease to 28% during the PCI era. There's a nice graphic here from a review article in the European Society of Cardiology Heart Failure Journal that extrapolated the Sweetheart data and mapped it from a comparison of heart failure inpatient versus the incidence of PCI. And you can see as PCI incidence has increased in the orange line, the subsequent development of heart failure while during hospitalization has significantly decreased as well. And then finally, the other consideration is the heart failure onset after discharge. So 13% of patients at 30 days typically develop heart failure, and then there's a risk of 20 to 30% at 1 year, and then subsequently an annual risk of 1.3 to 2.2%. So now we'll kind of get into some of the prior data, and this talk is not geared at the historical data, so I will not go into great depth just out of the interest of time, and I also only have 25 to 30 minutes to cover a relatively broad topic, so the breadth of the talk will not be as in-depth, but just want to hit some highlights. So perhaps the granddaddy of them all in terms of post-MI heart failure, the SAVE trial. I actually just yesterday was having a conversation with one of our faculty about how they were recalling passionately arguing the dose of lisinopril for a patient while they were house staff trainees on service. And, it really kind of all, I believe, emanated from this trial that enrolled, a little over 2,200 patients with acute MI complicated by asymptomatic LV dysfunction. And shockingly, captopril led to a 19% reduction of all-cause mortality and a 36% risk reduction of progressive heart failure. Really, outstanding numbers for the time. There was the subsequent GISI-3 study in the Lancet in 1994 that demonstrated mortality benefit with ACE inhibitors after MI, and the notable component of this was that this was regardless of subsequent LV dysfunction. So really cementing ACE inhibitors in the management of post-MI patients. And I just, preparing for this talk, really it was remarkable to me how much these physicians and researchers here listed below have really contributed such fantastic and pivotal data to our management of these post-MI patients. Later in 2003, the Ephesus trial evaluating eplerenone in patients with left ventricular dysfunction after MI. So this was a little over 6,600 patients enrolled, found to have significant reduction in death from cardiovascular cause or hospitalization for cardiovascular events with patients with acute MI complicated by LV dysfunction and heart failure symptoms, or LV dysfunction without heart failure symptoms and type 2 diabetes. It ultimately resulted in a 15% risk reduction of hospitalization for heart failure, and really kind of also cemented the MRAs in the management of post-MI patients. Another trial I wanted to highlight in terms of more historical data was specifically related to mechanical support and the intra-aortic balloon support for myocardial infarction with cardiogenic shock trial, the IABP Shock 2 trial. While cardiogenic shock is, on the extreme end of the spectrum of heart failure post-MI, I think it's important to highlight this study in that it enrolled 600 patients with cardiogenic shock complicating their acute MI with a primary endpoint of 30-day all-cause mortality. 119 of the 300 balloon pump patients and 123 of the 298 standard of care controls died at 30 days. So a relative risk with the balloon pump of 0.96 and a 95% confidence interval of 0.79 to 1.17. So really didn't find statistical significance in survival with the balloon pump. What I found was particularly interesting and potentially helpful from this study, though, is that there was no significant difference in the rates of major bleeding, peripheral ischemia, sepsis, or stroke between the control and the balloon pump patients. Now, this is, I would say, should not be confused with potentially how we typically utilize balloon pumps at our institution, and in the present day, where it's really more of a bridge to therapy for the majority of our folks that with cardiogenic shock that we have in the cardiac ICU, but nonetheless, certainly an important study to keep in mind in terms of historical data. I do want to pivot now to the current research in the management of post-MI, and I certainly recognize that there are numerous studies that I left out in terms of the historical data. And again, my focus is not on the historical data per se for this talk. I recognize I did not include one of the main tenets as well, beta blockers. And that's more so because the conversation's a bit nuanced regarding them in terms of, is the patient in cardiogenic shock? When can we initiate beta blocker therapy? And I really wanted to focus more on the ACE inhibitors as kind of the cornerstone for therapy as one of the most important medications to initiate in the early hours of post-MI patients with heart failure. So current research in management of post-MI. I'm not going to spend a lot of time because Xiaobo already did a very nice introduction of the CANTOS trial, or the canakinumab anti-inflammatory thrombosis outcome study. And admittedly, this study wasn't necessarily geared towards evaluating heart failure complications after MI, and actually more to prevent future events and control inflammation. But I set the stage here and include this article because I think it really was foundational in developing this theory of the inflammasome, which I'll reference in a few slides, and potentially the future for management of our patients with atherosclerotic coronary disease and their risk factors for future myocardial ischemia and infarction. And so again, just as a reminder, as Xiaobo so eloquently already illustrated, this was evaluating the effect of canakinumab, the monoclonal antibody to IL-1 beta, which has downstream modulation effects to IL-6 and known inflammation. Additionally, the patients needed a CRP greater than or equal to 2, with the primary efficacy endpoint of non-fatal MI, non-fatal stroke, or cardiovascular death. And this was really assessed with 3 doses of canakinumab, 50 milligrams, 100, or 150 milligrams against placebo. And really just briefly, because Xiaobo already went over this, I just want to highlight, really they were seeking to see a reduction in CRP level, and you can see in the blue line in the control, and then a significant reduction in all doses of the canakinumab, with no real significant impact on cholesterol levels or triglyceride levels. And really kind of it came down to like a Goldilocks type of dose, and it looked like the 150 milligram dose was the most efficacious in terms of the primary endpoint success, with the 150 milligram really showing the best confidence interval, though it does start to approach 1 with a 95% interval of 0.74 to 0.98. And this is just briefly to highlight the differences with the 50 milligram, which actually was not statistically significant, and the 300 milligram, which as a higher dose did not afford any significant additional benefit. And then finally, I think the reason that I also included this was that there was a key secondary endpoint in terms of the rates of hospitalization for urgent revascularization. And the canakinumab did appear to decrease this rate with statistically significantly with the 150 milligram dose, as you can see here. And so this would not be a heart failure talk if SGLT2 inhibitors, I don't think, were discussed. And so there was some really, I guess, data or research that was initiated in 2022 that showed some promising potential for SGLT2 inhibitors, specifically empagliflozin, for the management of our post-MI heart failure patients. And this was the EMI trial, which was published in the European Heart Journal in 2022. The one thing I'd like to highlight, though, is that this was not specific patient outcomes. This was really a biomarker-driven study. And so the investigation, this nice figure here on the right shows you kind of their inclusion criteria and what they were evaluating and their ultimate outcomes. But it investigated the impact of Jardiance on the biomarkers of heart failure in patients with MI, both with and without type 2 diabetes within 6 months following their event. They were randomly assigned Jardiance 10 milligrams or placebo within 72 hours of their PCI. And the primary outcome was an NT-proBNP change over 26 weeks after the event. And it was associated with a significantly greater reduction in NT-proBNP, significant improvement in LV function by echo as well. And so you can see some of their inclusion criteria was a CK greater than 800 and a troponin T or I level greater than the 10 times the upper limit of normal. They're able to enroll 476 patients, and they're randomized to the Jardiance or placebo group. And then the primary outcome did show a reduction in the NT-proBNP in the Jardiance group, but also secondary outcomes were notable for an increase in the LV ejection fraction, a decrease in your E to E prime values, a decrease in the LV in systolic volume, as well as in diastolic volume. And this is just some of the graphical representations from the article of these same parameters. So here is the NT-proBNP with your Jardiance in the yellow-orange curve here at week 26, with an overall 25 or essentially 26% reduction in NT-proBNP. And then these are just the graphs similarly for the left ventricular ejection fraction in the upper left, the E to E prime value reduction in the upper right, your LV in systolic volume in the lower left, and then the end diastolic volume in your lower right. So as you can see, the biomarker study seemed to show a lot of promise in terms of management of acute MI, and perhaps we had a new modality to implement in our post-MI patients. And so this prompted the IMPACT-HF study within the New England Journal, which was just released less than a month ago, and really assessing empagliflozin after acute myocardial infarction. So this enrolled a little over 6,500 patients to receive either 10 milligrams of Jardiance or placebo. But interestingly, Jardiance did not lead to a significantly lower risk of the composite endpoint. And the composite endpoint included first hospitalization for heart failure or death from any cause. And you can see over here in the table on the right, so we have here in this left column, the Jardiance group, and in the right column, the placebo group. The 95% confidence interval for the first hospitalization for heart failure was met within the Jardiance group, but that's not totally unsurprising because we know that this is a new tenet of heart failure management. But death from any cause was not statistically significant. Thus, the primary composite endpoint was not met for statistical significance. Similarly, though, rates of secondary endpoint events were not met for statistical significance either. And these include total number of hospitalizations for heart failure or death from any cause, total number of non-elective cardiovascular hospitalizations or death from any cause, a total number of non-elective hospitalizations for any cause or death from any cause, and hospitalizations for myocardial infarction or death from any cause. So really kind of overall a bit of a disappointment based upon the results of the biomarker ME study and then the actual implication in clinical outcomes with the IMPACT-MI trial. I'll then shift gears to our PARADISE-MI trial, which was really pursued because of the overwhelming success of prior RAS blockade trials, namely the SAVE, as I mentioned. And so this sought to evaluate the angiotensin receptor neprilysin inhibition in acute MI. And so a little over 5,600 patients were randomized to receive either sacubitril valsartan or ramipril. They did not have a prior history of heart failure. And then interestingly enough, treatment with Entresto did not reduce the composite endpoint, composite primary endpoints, which included death from cardiovascular causes, hospitalization for heart failure, and outpatient episode of symptomatic heart failure. And we had a 95% confidence interval of 0.78 to 1.04 with a p-value of 0.17. The safety profiles were similar, however, though there was a greater discontinuation for hypotension in the Entresto group and for cough in the ramipril group. And then additionally, with this study, similar to the IMPACT HF study, none of the secondary outcomes were met. And this was similar to the IMPACT HF study in that these were death from cardiovascular cause or hospitalization for heart failure or outpatient heart failure, death from cardiovascular cause, non-fatal MI or non-fatal stroke, deaths from cardiovascular cause and total hospitalizations for heart failure, MI, or stroke, and then death from cardiovascular cause and death from any cause. So really kind of showed that Entresto was not superior to ramipril, and that apparently both could be utilized in the acute management of heart failure in the post-MI patient. This, in an effort to further identify, well, maybe was this related because we just took all comers with MI and we did not stratify based upon STEMI versus in-STEMI. And so then there was a pre-specified sub-analysis of the Paradise MI that was performed. And really the eligibility criteria were essentially the same because they had already been enrolled in the Paradise MI. But again, acute MI within half a day to 7 days with an EF less than 40% and or pulmonary congestion, and then greater than or equal to 1 risk factor that augments risk for heart failure or death. And so then they stratify these patients into the STEMI group and the in-STEMI group, with a little over 4,200 in the STEMI and 1,300 in the in-STEMI. And they also saw that with this pre-specified sub-analysis that there was no statistical significance in terms of primary endpoint outcomes with Entresto versus ramipril. And you can see here on the left in the STEMI group, 95% confidence interval of 0.73 to 1.04, and in the in-STEMI group, 0.75 to 1.25. So really kind of supporting the main findings of the Paradise MI trial, and then also confirming that regardless of the type of MI that they presented with, there was no statistical significance between Entresto and ramipril. And so with the remaining time that I have left, I want to kind of finally shift gears into some future efforts because, admittedly, when I was preparing for this topic, it seemed that there was a lot of buzz in the last 5 to 7 years about new potential therapies for management of the post-MI patient, because as I highlighted in the kind of historic literature, it really wasn't since 2003 that we kind of had a profound article that really kind of shifted our management of the post-MI heart failure patient from the Ephesus trial. But really, a lot of the data has been a bit lackluster, or I should say probably at best non-inferior. And so there is some new excitement about some potential future therapies that are undergoing active research. And in the background, one of them is this nice, elegant artist portrayal of the inflammasome, actually on the Novartis website, which has a hand in a lot of this research. So future hypothesized management of the post-MI heart failure patient. So we've identified new pathophysiologic mechanisms in recent years to contribute to this adverse remodeling. And these are really kind of focused on the inflammation aspect of it. What is the post-MI metabolism within cardiac myocytes? And then the fibrosis that we know typically replaces the cardiac myocyte and kind of just overwhelms the scaffolding to create just a structure for the heart, but otherwise really doesn't participate in active myocardial contraction. And so this has led to the potential for large inter-individual differences specific to these pathophysiologic mechanisms, and raised the question, is there a role for assessing CRP in addition to BNP and renal function, et cetera, our typical labs for our heart failure patients? Is there a role for new patient-specific biomarkers to guide treatment that we haven't yet identified? And then it really just contributes to the hypothesis that medicine is continuing to evolve to highly individualized care. So one of the big areas of research is these small vesicles and nanoparticles. And so in the European Heart Journal this year, an article was published depicting the intracoronary delivery of extracellular vesicles from human cardiac progenitor cells, which was found to reduce infarct size and porcine acute myocardial infarction. So these nanoparticles are secreted by cells. They are bioactive molecules that modulate the recipient cells. In this particular study, these nanoparticles were derived from human cardiac progenitor cells. And the study investigators had porcine models that they ballooned the mid-LAD for 90 minutes to mimic an MI. And then they injected 6 of the pigs with intramyocardial, 6 with intracoronary, and then 5 vehicle controls with the bioactive nanoparticle molecules. And then at the 3-month endpoint, EF was significantly increased and infarct size was significantly decreased, specifically in the intracoronary group compared to control. And this is just an illustration from the article. And so you have the LAD occlusion for 90 minutes here at day 0. 1 pig did die, and then they performed an MRI follow-up on days 2 and 3, 1 month and 3 months. 3 months, and then you can see here for the EF percentage, the intracoronary nanoparticle infusion did have a slight increase in but statistically significant increase in the EF to, it appears to be somewhere in like the 37% range, as opposed to 33 to 34% in the control. And then similarly, they found that the infarct size in the intracoronary nanoparticle pigs was smaller compared to control, and then the infarct volume was also smaller than when compared with the control. This has actually prompted a state-of-the-art review article in the European Heart Journal, kind of discussing the role for extracellular vesicles and injury minimization after MI. Unfortunately, I don't have enough time to kind of delve into this, but it really gives a lot of really fascinating and encouraging data for the potential role for these nanoparticles and their future use in the post-MI patient. Additionally, there was, and this actually I think dovetails nicely with Xiaobo's talk in terms of the neurocardiac axis. And so in Circulation, there was an original research article published that in 2024, this year, that showed or described the piezo-1 complex and how it mediates neurogenic inflammatory cascade, exacerbating ventricular remodeling after MI. And so we've identified that there is a large component of neurogenic inflammation that promotes remodeling after MI and accelerates the development of heart failure. They identified this transmembrane protein known as piezo-1 in the dorsal root ganglion, and it participates in this neuroinflammatory response. It allows for calcium influx and therefore activates neurons to release IL-6, which we know has been proven in the prior studies that both Xiaobo and I mentioned, a pivotal role in inflammation and atherosclerosis progression. And the piezo-1 protein and mRNA and its associated mRNA were shown to be markedly increased at 4 weeks post-MI in murine models. So potentially a target that we might be able to kind of hijack in the future in terms of reduction of inflammatory cascade and the inflammasome. I would be remiss not to include the fantastic work that many of our colleagues here at VCU have been working on regarding anakinra and the blockade of interleukin-1. Really some fantastic work, and it's really neat to see those involved in the research at the bedside in the CICU with our post-MI patients, and really excited for their current endeavor with the VA ART4 research and the hopeful result in improvement in LVEF in these folks, and the incorporation of cardiac MRI and echo and reduction in the general inflammatory state. So excited to see the results that they're able to produce with their current research endeavor. And then finally, with the few remaining minutes that I have, I just wanted to highlight a potential mechanical, mechanical device to address the heart failure in the post-MI patient. Largely or traditionally, these mechanical devices have not seen a lot of success in the management of the post-MI heart failure patient, and really it's more of addressing the volumetric issue in dilated cardiomyopathy. However, there is a biological company called Bioventrix that currently has a study called REVIVE-HF. That's a prospective multi-center randomized control trial that is undergoing for the treatment of ischemic cardiomyopathy induced CHF with the Revivant TC system that is proprietary to them, plus guideline-directed medical therapy versus guideline-directed medical therapy alone. And for the sake of time, I just wanted to include this video. It has no sound, so I'll be your humble narrator for this. But basically, the device will be inserted into the right heart, but targeting this dilated left side, and then there will be a percutaneous needle inserted through the chest wall into the LV, at which point a guide wire will then be inserted once the needle crosses the septum. So there's the guide wire that is inserted under fluoro. It then will retract several devices through the right side of the heart, and then advance an introducer over the wire. And then another introducer sheath will then be introduced from the left side, which will allow for essentially these clips to be then distributed from the right side across the septal puncture to then hopefully facilitate volume reduction. So there is the clip on the right side that's been inserted, and then we've now got the clip from the left side, which will then try to hopefully reduce the ultimate volume of the left ventricular cavity, and in essence to hopefully improve symptoms and ultimately the complications related to dilated cardiomyopathy secondary to ischemia. So without further ado, my summary for my talk. So the heart failure in general remains a challenging disease course to manage, both in the acute and chronic features, and is responsive to variable medical regimens. I think it's important to keep in mind that we have, for the post-MI patient, heart failure at the time of MI presentation, heart failure develops during hospitalization, and then heart failure following discharge from index hospitalization for MI. But also not to forget the chronic heart failure, because that's really where our guideline-directed medical therapy that we have is more geared towards, as opposed to the heart failure due to acute MI. Neurohormonal blockade remains a cornerstone of the post-MI heart failure management, despite new drug therapies, and which was really kind of corroborated by the more modern research data that we have. However, there is exciting new technologies that are occurring, and I think the inflammasome may be the most promising targeted therapy of this decade, and potentially plays a pivotal role in both acute MI, but also preventive cardiology. And then invasive volume reduction procedures remain largely unproven, but there perhaps might be a role for these devices in end-stage symptomatic improvement. And could this perhaps be a new destination therapy as we have for like our VAD patients? So I know I'm just over time and I apologize, but I will go ahead and give the last slide.
Thank you for that wonderful talk, Dr. Ali. Really appreciate it. I know that we're a little over time, but if anyone has any questions, please feel free for Dr. Xiao and Dr. Ali. We'll take questions. All right, I don't see anything coming through on the chat. If anyone has anything to add on the Zoom meeting, otherwise we will wrap up. Thank you guys so much. Please have a wonderful day.